Why was he so stiff? Why are his pupils so large? Why is he not waking up? Why is his blood pressure so high? What is making him tachycardic? And what's up with the apnea? Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Hey guys, and welcome back. This episode is kind of a two-parter. I shared with you a bonus episode a few days ago that just had the case without the diagnosis to give you a chance to work through all the differentials yourself. And if you guessed serotonin syndrome, well, you were correct. For those of you that missed the bonus episode, I would recommend going back to listen to the whole thing. It was short, but awesome with a lot more details, but just real quick to refresh your memory, here is the meat and potatoes without all the details from this case. Upon arrival, the patient was laying in the bed, and Hannah said, just watch his breathing. Okay, so I watch as he has several periods of apnea, and his oxygen saturation is dropping, but then he would just start breathing spontaneously, and his oxygen saturation would improve. When I saw the first apneic period, of course, I tried to wake him up to get him to take some more breaths, but he was completely unaffected by my attempts to wake him up. He barely responded, even to noxious stimuli. So I also noted that he felt very warm to touch. My mom hands estimated about 100 degrees Fahrenheit. So not burning up, but just warm and a tad kind of diaphoretic. But my assessment just kept getting weirder and weirder. In trying to get him to respond to me, I noted that he was so stiff. Like his arms and legs were rigid. I mean, they were movable, so not tonic like a seizure, but oddly stiff. And his pupils were pretty big. I'd say between 4 and 5 millimeters, but equal and slowly reactive bilaterally. So he was tachycardic, like in the 120s, hypertensive in the 190s systolic, but his respiratory rate was all over the place. So many periods of apnea, followed by periods of tachypnea. And I mean, he would go from no chest rise and fall to breathing 50 times a minute. Like his oxygen saturation was great when he was breathing, but it would dip as low as about 89% when he was having an apneic period. So I ask, what's his baseline? Like, what's he here for? He had just come out from the ER a bit ago. He had come in because his son called 911 for seizures. And when he came to the ER initially, he was talking. Now, he was altered, but talking. But now, I couldn't get him to wake up. Evidently, he was somewhat agitated in the ER. She ended up giving him benzos and started him on dexmedetomidine. When the PCU nurse couldn't awaken him, well, she stopped the dex, and it had been off for about 30 minutes by the time that I arrived. So the dexmedetomidine shouldn't be the reason anymore why he's so out of it. At this point, I'd seen enough. We didn't have a good reason for why he was having these periods of apnea. I mean, he was fairly young. He didn't have the typical build of someone who had sleep apnea. There were just too many other strange things. Like, why is he so stiff? Why are his pupils so large? Why is he not waking up? Why is his blood pressure so high when he's sleeping? Like, what's making him tachycardic? I wanted some more diagnostics to figure out what was going on with this guy. So I called the hospitalist, and I'm sharing with him all my concerns. And he's like, yes, these are great questions. Let's just call a rapid response. So at my hospital, initially what I was doing was what we call a nurse consult, where the rapid response just comes and supports the bedside nurse. So when we call a rapid response, that gets the ICU provider and a respiratory therapist and a phlebotomist to the bedside in addition. So we called the rapid response, and while I was waiting for the ICU residents and the respiratory therapist to arrive, I started to dig in the chart a little bit more. So it turns out this patient's a known alcoholic. He actually was admitted recently for alcohol withdrawal. He was positive for benzos and cocaine on his drug screen in the ER. His creatinine was 2.4, his sodium 154, his anion gap 22, his ammonia level was only 33, his white count was 22.5, but I couldn't really see a clear source for his infection. Like all of his imaging had come up fine. He had a negative head CT, negative abdomen pelvis. The septic workup was started in the ER. Like they got blood cultures, which are still pending, obviously. His lactate was 1.6. In the ER, he got that 30 cc's per kilogram bolus and broad spectrum antibiotics and a bunch of imaging. And then they sent him to the PCU on a dexmedetomidine drip because of his agitation. So here I have a minimally responsive patient with periods of apnea who's super rigid and warm to touch. I describe all of these things to the ICU resident, and he whips out a reflex hammer from his pocket. Now, I thought I was prepared with my fanny pack, but this guy totally showed me up. Sure enough, the patient was hyperreflexive with ankylosing. So we got an ABG. It showed metabolic acidosis. His oxygenation and ventilation were actually fine. I gave him verapamil for his hypertension because of the cocaine in his system. We gave Ativan, and I started a dexmedetomidine drip back up as my shift was ending. So based on our clinical findings and his history, the decision was made to upgrade the patient to the ICU. What do you think was causing all Mr. James' symptoms? Why was he so stiff? Why are his pupils so large? Why is he not waking up? Why is his blood pressure so high? What is making him tachycardic? And what's up with the apnea? So, if you had guessed serotonin syndrome, at what point did you figure it out? For me, it was the ankylosing. I mean, honestly, the periods of apnea were kind of throwing me off because for some reason I always associated serotonin syndrome with all of these like amped up type symptoms. Restlessness, agitation, disorientation, tachycardia, hypertension, tachypnea, hyperreflexia, seizures. So apnea doesn't really fit in with that list of hyperactive type symptoms. It's like when you were elementary school and they would give you those questions like, what doesn't belong here? Where they would have a bunch of pictures of, say, like sea creatures and then a cow mixed in there. And you're supposed to be able to know that cows are land animals and don't fit into the category of sea creatures. Yeah, so apnea doesn't exactly make me think serotonin syndrome. But when I went home and searched the literature, like I always do when I discover something that I don't understand, I discovered that actually apnea can be associated with serotonin syndrome. And I will get to that. But first, let me back up to the definition and the basic patho, and then we'll review the physical findings and how to treat serotonin syndrome. All right, so serotonin syndrome is a potentially life-threatening condition resulting from an excess of serotonin in the central nervous system. Serotonin is a neurotransmitter that plays a key role in multiple bodily functions and is known as the feel-good hormone. People who are low in serotonin often have symptoms of depression, and there are drugs that boost serotonin, and those drugs in excess can lead to serotonin syndrome. This syndrome, although rare, is actually becoming increasingly relevant because of the widespread use of serotonergic medications. Those would be meds like selective serotonin reuptake inhibitors, or SSRIs, or serotonin norepinephrine reuptake inhibitors, or SNRIs, or monoamine oxidase inhibitors, or MAOIs, or tricyclic antidepressants, TCAs, or other meds like pain medications, like tramadol, for example, anti-migraine drugs like all the triptans, and illicit drugs like cocaine and ecstasy and LSD, and even some over-the-counter supplements like St. John's wort. All of these will increase the amount of serotonin in the system. So the syndrome can occur due to drug overdose or just like an interaction between multiple serotonergic drugs given at the same time, and occasionally just from increasing the prescribed dosage of serotonergic medications. Hey guys, I just wanted to take a quick break to talk about something that I think is really important, and that is getting certified in your nursing specialty. Not because having the extra letters behind your name make you a better nurse, but because taking the time to deep dive into all that you need to know for your specialty putting in the study hours and dedicating yourself to mastering what your patients need you to know how to manage them best, the prep for the exam, is what will make you a better nurse. So whatever specialty you are currently working in, go study for that certification exam. And if you're a critical care nurse, I have something that will help you pass your CCRN. My friend Nick McGowan has an excellent online self-paced CCRN prep course called Critical Care Academy. It is so thorough, and he has broken down everything you need to know into little bite-sized digestible content that he calls micro-learning. Let me tell you, the CCRN is the hardest test I've taken in my entire life. You don't want to go it alone. You want to take this course to ensure that you know your stuff before sitting for the exam. If you'd like to check out his course, you can find it at ccrnacademy.com. And great news, just for being a Rapid Response RN podcast listener, you get 10% off the cost of the course by using the coupon code RAPID10 at checkout. So if you've ever considered getting your CCRN, do it. And let Critical Care Academy help make sure that you will pass. I'll put the link and coupon code in the show notes. So, the pathophysiology of serotonin syndrome involves excessive stimulation of serotonin receptors in the central nervous system. Serotonin is a neurotransmitter, like I said. It helps to regulate mood, cognition, and autonomic functions. The overstimulation primarily leads to a cascade of multiple clinical manifestations affecting the autonomic system, the neuromuscular system, and mental state. So, under the autonomic dysfunction, you would see symptoms like hyperthermia, diaphoresis, hypertension, tachycardia. Serotonin also influences the spinal cord and the peripheral nerves, resulting in symptoms like myoclonus, like sudden muscle jerks, hyperreflexia, like these exaggerated reflexes, tremor, and clonus, or like muscle contractions. So if you've never assessed for clonus before on your patients, I'll put a link in the show notes for you to watch a video of it because it's kind of difficult to describe with just words on a podcast. But basically, you stabilize the patient's leg just above the ankle with one hand to keep it steady. And with the other hand, you quickly and firmly dorsiflex the foot by pushing the toes towards the patient's head and hold in that position. You're looking for rhythmic involuntary oscillations of the foot, and those involuntary jerks, so to speak, are called clonus. So count them because typically it's considered abnormal if there are 5 or more beats or jerks counted. Okay, and then finally, overstimulation of serotonin receptors in the brain causes confusion, agitation, hallucinations, and in severe cases, seizures and coma. By now I'm sure you're asking, but Sarah, what about the apnea? Yeah, great question, because I had the same question. So let me try to break it down. There are 2 main categories of sleep apnea. Obstructive sleep apnea, which is very common. This is an anatomical problem where there's a physical blockage of the airway leading to long periods of apnea. There's also central sleep apnea, which involves a failure of the brain to signal the muscles to breathe. While serotonin syndrome does not directly cause sleep apnea, it definitely can influence factors that contribute to the development or exacerbation of sleep apnea, particularly through autonomic dysfunction and neuromuscular effects. And sometimes even the impact of the medications that we used to treat serotonin syndrome. So there's a handful of studies showing a link between those who take SSRIs and worsened sleep apnea. So if SSRIs worsen sleep apnea, imagine how much worse it can be with the excessive amount of serotonin levels seen in those with serotonin syndrome. The disruption of autonomic functions can exacerbate central sleep apnea and make individuals more prone to obstructive events by affecting muscle tone and airway patency. Additionally, many of the medications we use to treat serotonin syndrome, like the benzos that were given to Mr. James in the ER, those cause sedation and can also contribute to central sleep apnea. So it's not one of the primary symptoms of serotonin syndrome, but sleep apnea can definitely be exacerbated by excessive serotonin. But in summary, the classic trifecta in serotonin syndrome are first, change in mental status, which change could mean anxiety, agitation, seizures, or worse, coma. The second in the trifecta would be increased sympathetic hyperactivity, which that could present as hyperthermia, tachycardia, hypertension, diaphoresis, and then the third is that neuromuscular hyperactivity. So this looks like akesthesias, inability to remain still, hyperreflexia, hyperkinesis or tremors, clonus, and muscle rigidity. Okay, now let's talk about the treatment. The first most crucial step is to immediately stop any of the serotonergic drugs. This cessation typically leads to an improvement in symptoms in 24 hours. So look through the MAR to see if there are any drugs on the list that might be contributing to this excessive serotonin state. Next, you're really just treating the symptoms. For hyperthermia, external cooling measures like a cooling blanket and IV fluids are employed to manage dehydration and lower the body temperature. Don't bother with antipyretics. This is not a hypothalamus-mediated fever, so use other cooling methods. Sedation may be needed if the patient is agitated. Benzodiazepines are used to control agitation, tremors, muscle rigidity, and they would also help with seizures if the serotonin syndrome is that severe. Dexmedetomidine is another great medication for this patient population as it actually reduces the sympathetic tone and causes sedation. However, it doesn't have any anti-seizure properties, so benzos may still be needed, or propofol if the patient is intubated. Now, I have never given this drug, so I'm probably going to pronounce it wrong, but cyproheptadine is an antihistamine with serotonin-blocking properties that can help mitigate symptoms by inhibiting serotonin receptors. It should be administered in a large loading dose and then a maintenance dose every 6 hours until the symptoms are resolved. Okay, let's wrap it all up. So Mr. James had consumed enough cocaine to throw him into serotonin syndrome. He likely had some other serotonergic medications on board, but he was unable to provide us with a thorough medication history whenever he met his healthcare team. He presented with many of the classic symptoms of serotonin syndrome: agitation, confusion, he did have a seizure, hyperthermia, tachycardia, hypertension, tachypnea, diaphoresis, hyperreflexia, clonus, and muscle rigidity. But he never required intubation. We just controlled his symptoms, sedation, prevention of seizures, blood pressure control, etc. And we treated his acute kidney injury with IV fluids until all of the serotonergic meds cleared from his system, and he was ultimately discharged. So there's no test to confirm the presence of serotonin syndrome. We can do diagnostics to rule out other possible causes, but diagnosis is made based on the constellation of symptoms. And Mr. James was exhibiting the bulk of them. So I hope you enjoyed this mystery episode reveal. I really think this is a blast, and I loved hearing all of your guesses earlier this week. So if you think that you have a great case for a future mystery episode, send me a message on Instagram. I would love to hear all about it.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.